turn my camera on when just 10 minutes from the end.
Brilliant. I've got a little stopwatch as well. Hopefully you can see my screen and you can hear me loud and clear.
Yeah.
Amazing. Thank you very much, Fintan. Thank you very much, Selena. It's wonderful to be here. Thank you very much for inviting me. It makes total sense that I follow up from Fintan because there's a lot of things that we're talking about which cross over. But hopefully you can see my screen. And yeah, today I want to basically reframe how we understand chronic migraine, not just as a purely, I guess, neurological disorder, but as a systemic condition that involves both the gut and neural interactions. And I'm sure Fintan came across some of these things when he was researching his conditions as well. I think this topic is particularly relevant for those working in pain because, as Fintan alluded to, a lot of the mechanisms I'm going to be talking about today extend beyond migraine to other chronic pain conditions. And I think, similar to Fintan, the key question here is whether targeting the gut through things like diet and probiotics could represent a genuinely disease-modifying approach as just in contrast to just a symptom-relieving approach. I've got here, you're probably questioning why I have a Giorgio de Chicureo painting here, but basically, as I was doing some research for this talk, I noticed that this painter, Italian painter, suffered from chronic migraine himself, and I was looking at his paintings and thought that, you know, a lot of the paintings have like this weird kind of abdominal stuff going on. So I thought there's some potentially fun interaction here between he had migraine with aura, so he had these weird visions of the world. So potentially there was something going on here, and some art critics have argued that Giorgio suffered from abdominal symptoms as well as his migraine as well. So there was kind of some funky paintings there. So why do we want to rethink migraine or chronic migraine as an abdominal or GI thing as well? Well, many of you, who are in clinics and chronic pain clinics will come across chronic migraineurs who just describe their headache not only as a headache thing, but also an intensely kind of whole body experience. And this is backed up by some surveys and research which shows that over 70% of migraineurs report GI symptoms with like nausea, bloating, abdominal pain alongside their chronic migraine. Indeed, there's also a kind of high overlap between GI conditions like IBS, celiac disease, and IBD with migraine. And if you take a cohort of migraineurs, they'll often have these conditions. And likewise, if you take a cohort of people with celiac disease, many of them will have chronic migraine as well. And in those who work in pediatrics, and particularly pediatric GI clinics, you'll undoubtedly have come across the functional disorder of abdominal migraines, which has a similar, people think has a similar pathophysiology to kind of head migraines. And it's this weird kind of depolarizing effect across the enteric nervous system of the gut. So there's a link there indeed. And I'm sure people who've been in clinics with migraines, the patients will frequently describe their attacks as having a food trigger. We'll talk later a little bit about caffeine and wine and that kind of thing. And indeed, I did a small survey for this essay, like a small online survey, about 50 people. And people said that in this response to the kind of open text response to the survey that typically they said things like my IBS flares with my migraine attacks, or my stomach is in agony during migraines. So it's a recurring thing that comes up in patient interaction. And it's interesting that Fintan talked about similar things to this, but it's interesting that research now is starting to really validate what patients have been saying for a long, long time. So it feels like research is catching up with patient experience. This big dramatic picture here, I thought would be kind of fun to put here, but this is an example of trepanation. So it's where it's been going around for about 7,000 years ago, this skull is from, and it's essentially an old treatment for migraine where people would drill into the holes of migraineurs and try and release the evil spirits. So it's a pretty dramatic photo there. I'm sure some people among here will know William Harvey, the 17th century physician, who I think is more often associated with blood and circulation, but Harvey recommended trepanation as a treatment for migraines in the 17th century. So I myself suffer from migraines occasionally, and sometimes it feels like drilling a hole in the skull to release fluid was somehow, there's some logic to it, I guess, but it seems like a pretty horrific thing. And many people died from obviously from sepsis and stuff as a result of this treatment. And very quickly, just running through the history of the connections between gut and brain and the gut-brain axis. Hippocrates, everyone knows about, 5th century BC Greek physician, often described the stomach and the head as interlinked, and he described that when the stomach is disordered, the head suffers. Galen, a bit later on, kind of building on the back of Hippocratic theory, came up with this theory, the idea of dyspepsia leads to toxic vapors, which leads to migraine, melancholy, and vertigo. So again, linking these two things together. Robert Burton, a bit later, talking, not a physician, but talking about the anatomy of melancholy, writes that the stomach is the foundation or the fountain of all disease, and from its distemper proceeds fumes that trouble the brain. And finally, a bit more modern, Edward Leavening, on writing on migraine, which is the first neurological treatise on migraine, described an abdominal prodrome to migraine. He described food triggers, and he described nausea as integral, not secondary, to migraine, writing that it's a constitutional disorder that involves both the digestive and the nervous system. So there's a long kind of history of migraine being associated with the gut, essentially. So moving to the present day, migraine currently affects about 1 in 7 people globally. It's extremely common. I'm sure that people here suffer from migraine. I myself suffer it from annoyingly, not chronically, just acutely, thankfully. And it can be divided into both migraine with aura versus migraine without, and it can also be divided into acute migraine versus chronic. International Classification of Headache Disorders defines chronic migraine as 8 or more migraine days per month for more than 3 months. And this chronic migraine classification affects about 8%, 8 to 10% of people who suffer from migraine. So it's a pretty debilitating way, particularly debilitating form of migraine. And these patients carry a very high burden of disease. They have increased rates of depression and have high comorbid chronic pain conditions as well. Very briefly, I'm sure neurologists amongst you or neuroscience people amongst you will probably disagree with this, but migraine is a very hotly debated condition pathophysiologically. My understanding is the dominant model involves this idea, I've got this diagram here, of cortical spray depolarization that activates the trigeminal vascular system, releases the CGRP or calcitonin gene-related peptide that causes vasodilation, neurogenic inflammation, and nociceptor sensitization, which is very similar to what Fintan was describing. And thankfully, we conclude on that model of chronic pain, and indeed it aligns with how migraine, the pathophysiology of migraine works. Current treatments for this kind of link to this pathophysiology. So many of you will know the mainstay of migraine treatment is triptans, which are selective 5-HT1B/D receptor agonists, so serotonin agonists, essentially, that aim to constrict dilated cranial blood vessels and inhibit the release of the CGRP from the nerve endings. We've got some newer treatments coming out, the CGRP monoclonal antibodies like arenumab and other hard to pronounce drug names. People who work in migraine will know that you often use propranolol, which is a beta blocker, obviously, as a prophylactic for migraine with some limited efficacy. And they also got topiramate, which is another treatment. So essentially, we've got some drugs here that work sometimes with prophylactically, like propranolol, but often with aiming for symptom relief effectively. If we're talking about the healthy gut-brain axis, moving on, as Fintan's kind of alluded to, that each of us carry this 4 trillion microbes in our gut, which is kind of a mind-boggling number to really get your head around. But 4 trillion microbes roughly divided across around 1,000 species of different microbes. And in a healthy person, in a state of health, this is a symbiotic relationship rather than a pathological one, obviously. And the communication kind of works via 2 main mechanisms. Obviously, it's incredibly complicated, but this is a 2-minute summary, is that they communicate via neural signaling via the vagus nerve, and also these chemical signals via microbial metabolites, which Fintan alluded to, which crucially includes the short-chain fatty acids like butyrate and acetate, and also cytokines and neurotransmitters. So I've also, Fintan's already mentioned how the short-chain fatty acids like butyrate, they're very crucial for maintaining the gut barrier integrity through the production of mucus and that kind of thing, and regulating inflammation as well in the gut. Crucially, again, it's mentioned by Fintan, but the system is bidirectional. So the brain, via the HPA axis, can alter the gut permeability and enzyme secretion within the gut, and also mucus production within the gut via cortisol production. And I've got a diagram that shows all this in a sec, because I know it's kind of hard to get your head around in an abstract way. So moving on from the idea of the healthy gut-brain axis, let's move on to this idea of dysbiosis and how that affects migraine. So when this system is disrupted via environmental factors like stress, poor diet, environmental pressures, cortisol increases, which increases gut permeability. And this changed gut environment tends to favor certain quote unquote to use the popular scientific term, bad bacteria or pathogenic species and suppresses beneficial ones. So there's various studies that have shown that there's increased levels of so-called bad bacteria in chronic migraineurs, and this includes species or genii including Tissuella or Vignerea and Coprobacillus. And I think Vignerea is the bacteria or the pathogen you can see on the right there. And at the same time, in chronic migraineurs, gut studies have shown that there's decreased levels of beneficial genera, like Bifidobacterium and Fecalbacterium and Lactobacillus as well. And on the left there, you can see a picture of Bifidobacterium. And in one striking study, there was we all know H. pylori is basically it's the enemy of medicine, and H. pylori is never a good thing. And one striking study that showed that eradicating H. pylori had led to a significant increase in migraine symptoms across a large number of patients. So this is the diagram I was talking about, just to kind of run down some of the mechanisms again of how the gut potentially impacts brain health. There's three main mechanisms that are being proposed, and again, it's linking to what Fintan said as well. The reduced production of short-chain fatty acids by the so-called bad bacteria potentially leads to impaired gut barrier function and increased inflammation as well through systemic factors and transporting in the blood. Secondly, gut microbes regulate amino acid production like tryptophans and tyrosines, which are precursors for serotonin, dopamine, and GABA, which are all very relevant in migraine pathophysiology. And thirdly, there's some emerging evidence that gut signaling may itself influence CGRP signaling via vagal inflammatory pathways as well. That's kind of emerging. As you can see on this diagram, the kind of main common pathway is this idea of all this stuff causing neuroinflammation and central sensitization in the brain. There we go. So as I said, I did a small survey of people online, migraines online, and people consistently reported certain food as triggers, particularly caffeine, red wine, cheese, and chocolate. It's stuff that comes up all the time in neurology, migraine clinics as well. And what is interesting across the patient perspective is that there's quite a lot of variability really in what, one person's trigger could be another person's safe food. And there's some studies that on some evidence that the idea that individual microbiomes may mediate the effects of these triggers. So if you have a certain microbiome, it might be able to manage certain triggers and vice versa. And many patients had in this survey described having trying a diet or trying probiotics and getting at least some measurable benefit from that. But I appreciate this online survey is not exactly scientific, but it gives a good sense of the kind of things that affect migraineurs on a day-to-day basis. Moving on very quickly to dietary interventions, there's a growing literature examining these dietary interventions to migraine, which Fintan's alluded to as well. Ketogenic diet, which basically involves high fat, high protein, and low carb diet, has been shown to reduce migraine frequency. Low glycemic diets also have similar effects. The DASH diet, or the dietary approach to stop hypertension diet, which many people have seen in a different context in cardiac and hypertension clinics, has been associated with improvement in migraine outcomes. And then more generally, as is the case with basically all of medicine, highly processed Western diets are associated with increased migraine risk and many other bad things, whereas this fantastic Mediterranean diet appears to be protective in some way. And this is likely to be to do some reduction in neuroinflammation effectively, and some changes in those short-chain fatty acids and various other precursors to neurosignaling. I'm very aware that there's also limitations of these diet studies. I just want to emphasize that, as Fintan mentioned as well, diet studies are very hard to conduct well. Adherence is very variable. Blinding is kind of impossible, and self-reporting, obviously, with diet studies introduces massive bias. And it's important to note that the biological mechanisms for how a ketogenic diet, for example, works, they're not really understood. So there's huge kind of variation here, huge bias, huge variation, and adherence is very difficult. So I appreciate that the evidence base needs to be expanded, basically. Moving on very quickly to almost done, but looking at probiotics, which is another kind of headline intervention. I just thought I'd include this article here that shows that in healthy people, this is specifically talking about healthy people, probiotics are actually very unhelpful. They don't really change the composition of the gut microbiota. But in people who are in a state of dysbiosis or unhealthy gut, they still have an effect and still can be helpful. And it's also worth emphasizing that, obviously, and I'm going to talk about this maybe in the questions, but the commercialization of gut microbiome stuff has meant that supermarkets and food producers obviously have a huge incentive to produce stuff that's marketed as probiotic or marketed as gut healthy and really doesn't actually have the actual strains of bifidobacteria or lactobacillus, for example, in their product. So there's a huge kind of commercial element to this that is worth talking about maybe in the questions. But talking about it in specific terms, probiotics in reality, in a scientific sense, are live microorganisms that confer health benefits when consumed. And a recent systematic review found that probiotics did reduce analgesia use in migraineurs. And there's various other studies that show, for example, by Matami et al. Showed that a 40% reduction in migraine frequency, which is about 2.6 fewer migraine days per month, when using probiotics, which you can imagine as a migraine, if you're a chronic migrainer suffering from 8 or more migraine days per month, 2.6 fewer of those days per month is a huge benefit. As I said, many of these good formulations, effective formulations of probiotics, have strains like bifidobacteria and lactobacillus in them. Right. Almost at the end, but here I want to talk a little bit about how, moving beyond migraine, talking about chronic pain conditions generally, what makes all this interesting is the mechanisms, as Finton's alluded to, are not just specific to migraine. So gut dysbiosis has been implicated in conditions like fibromyalgia, visceral pain, ankylosing spondylitis, neuropathic pain, and that's because microbial metabolites directly sensitize nociceptors and contribute to systemic inflammation, not just in the brain, but all around the body. Indeed, Flint has already alluded to the fact that there are experimental therapies emerging for all kinds of conditions, including interventions like fecal microbiota transplantation. And I think that raises the possibility that effectively the gut-brain pain axis could be like a new unifying framework or subspecialty that's useful in chronic pain therapeutics. Just very, very quickly talking about some clinical implications. So this supports the idea that a holistic systems-based approach to chronic pain is paramount. Diet and gut health are not some form of alternative medicine, but they're very biologically plausible and they're very useful as a therapeutic target. And I strongly believe that these approaches offer something close to kind of disease modification as opposed to symptom suppression. And as Finton's already talked about, in the future, we may want to personalize interventions based on individual microbiome profiles. And also really emphasize the importance of taking patients seriously, because for centuries and for decades, patients have been talking about the fact that the gut symptoms are linked to their migraine, and modern medicine didn't really take them seriously, didn't research it properly. So there's the ubiquitous and quotidian need to basically take patients seriously and listen to them, as in life. Some key take-home messages for everyone, just to conclude, that I think migraine is best understood as a systemic disorder rather than a brain-isolated one. The gut microbiome, if I haven't convinced you of this already, but the gut microbiome seems to influence susceptibility, severity, and treatment response across many different studies and across many different patient demographics. Dietary changes in probiotics show some real therapeutic promise, even if the evidence is in need of some expansion and some solidifying and validation, as Finton said. And I think now we need to move the field of chronic pain and gut-brain pain axis research needs to move from correlational understanding towards a more mechanistic understanding of how these things actually that they work. And if we get that right, I think that microbiome-based therapies could very meaningfully change how we treat chronic pain patients.